Okay. So, good evening and a warm welcome to all the dignitaries present here. I am Kashish from Clarinet, serving as the allocated session assistant to ensure a seamless experience. Clarinet proudly stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as the digital partner for this event hosted by the Oncology Integrated Society. So, the focus of today's session is surgical update on breast cancer treatment. And now I would like to inaugurate today's session with Ganesh Vandana.
So, hello.
I would like to invite Dr. Dipti Chaturvedi ma'am to proceed with this session.
Hello and welcome all to this yet another episode of Cancer webinar series. It's really a matter of honor and proud privilege to host this webinar from the aegis of the Onco Integrated Research Foundation, supported by Dr. Chaturvedi Cancer Hospital, Gorakhpur Private Limited, and Clarinet Team. Today we have with us two very learned, talented, and astounding, brilliant speakers, Associate Professor Dr. Shwetima Chaudhary from T.S. Mishra Medical College, Lucknow, and Associate AP Dr. Siddhant Singh, who is with us from SRMS Indian Medical College, Bareilly, and they both will be talking on update on breast cancer treatment. Uh, they will be speaking about the surgical and radiotherapy aspects. For sharing the sessions, we have with us Professor and HOD Oncology Department, RML Lucknow, a doctor full of knowledge and surgical skills, to chair the session, Dr. Ashish Singh, and also another lady full of wisdom and enigma, a woman with strength and resilience, none other than Dr. Rashmi Shukla, senior consultant from Max Super Specialty, Delhi, to chair the radiotherapy session. Presiding over the webinar, we have Dr. A.K. Chaturvedi, who is the man behind this society, this foundation, and who is renowned senior oncologist and owns his own Chaturvedi Cancer Hospital, Basharatpur, Gorakhpur, with a record experience of treating cancer patients of about 40 years, and who has been past president UPARI with extra trainings abroad, won many awards, publications to add to the extra feathers to his cap. The questions from the audience will be put in the chat box, which will be then pasted here in the faculty link so that they can be discussed at the end of the meeting. So now I call upon Dr. A.K. Chaturvedi to take the dais and carry on the further proceedings of the webinar. Dr. Chaturvedi, please. He did his MBBS MD from MGM Medical College Indore in radiation oncology, owner, as I've already said, past president, I also already mentioned, trained at Manchester for brachytherapy, electron, etc. And he has been co-guide to many theses in cancer in BRD Medical College, Gorakhpur, and has won many awards, papers, and publications to add to the feathers in his cap. Over to you, Dr. A.K. Chaturvedi.
Thank you, Dr. Deepti, for introduction. And we welcome all of you to this forum of Onco Integrated Foundation. And today we are gathered here to discuss about the breast carcinomas, which is a most common malignancy in females, constituting about 28.2% of all the female malignancies. As you know, we have tried to bring together surgical oncologist as well as radiation oncologist on this forum to discuss elaborately about how to manage the carcinoma breast, because it's a lots and lots have been written about it, and still we are having only guidelines. No definitive treatment is available. So today we have got eminent surgical oncologist as well as radiation oncologist. So first I invite Dr. Ashish Singhal. He is MS MCH. He is professor and head surgical oncology at RMLS Lucknow. He has graduated from AMU Aligarh, PG from PGI Chandigarh, super specialization MCH from KGMU Lucknow. And post super specialization, he was research fellow and observer at TMS Mumbai. He has done training in robotic surgery, observership in Galaxy Laparoscopic Institute, IPEC training in AIMS Delhi. He has got gold medal in MBBS experience. He has got 15 years of experience in the field of oncology at various prestigious institutions, member of editorial board of various journals. His area of interest is head and neck oncosurgery with a special focus on microsurgery of larynx and hypopharynx, oncoplastic breast surgery, minimal invasive surgery for esophageal cancer, peritoneal surface malignancies. His key achievements are he has established the Department of Ramanoa Lohia, Lucknow, pioneered the use of submental flap in various onco constructions, free flap surgery for reconstruction after osteonecrosis, oncoplastic breast surgery, peritoneal surface malignancy surgery. He has got many publications, nearly 24. So I invite Dr. Ashish Singhal for the chair as a chairperson. And our second chairperson is Dr. Rasmi Shukla. She is senior consultant, radiation oncology, Max Super Specialty Hospital, Patparganj. She has got 13 years of experience. She has done her DNB from Mahavir Cancer Sansthan, Patna, and MBBS from Odisha. She is a member of so many organizations, AROI, ISO, and IBS, IMA, ESMO. Her special interests are intensity modulated radiotherapy, IGRT, SRS, TSCT, and TBI, etc. So I welcome you also, Dr.
Thank
And
you,
now
sir.
now I request Dr. Ashish Singhal to please proceed with the surgical oncology part.
Thank you, sir. Thank you, sir, for the kind introduction. And without proceeding for further session, when no more delay, I welcome the speaker, Dr. Siddhant Singh. He is currently working as an assistant professor in the Department of Surgical Oncology at SRMS Bareilly. And he has done his MBBS from Maulana Azad Medical College, New Delhi, and MS from GSVM Kanpur. He has done his super specialty training from Max Super Specialty Hospital, Saket. And his active areas of interest is advanced robotic and minimally invasive cancer surgeries, IPEC, PIPEC, and head and neck malignancies, treatment of various gynecological malignancies, and breast oncoplastic surgery. He will be speaking on the update on breast cancer treatment with special focus to surgical part. So over to you, Dr. Siddhant Singh. Please take on the stage.
Thank you so much, sir. Before I begin, I would like to express my sincere gratitude to the organizers for giving me this opportunity to speak today. It's an honor to be here.
All
Share my
parents
screen.
ask.
Can I share my screen now?
Yeah.
So I hope it is visible.
It's visible.
Yeah.
Yeah, it is visible.
So good evening, everyone. And breast cancer topic very dear to my heart. But one single day is definitely not enough to discuss all the aspects of breast cancer. It's a vast treatment. As Sir rightly said, breast cancer has surpassed all other cancers, both in females and as a whole. And it's now the most common cancer in the entire world, in India as well. In India, if you talk about India, it's approximately 30, more than 30 cases per lakh women that we see. More so in the southern part of India, probably because of higher literacy rate. The mortality has no doubt come down over the decades, probably because of better treatment, early diagnosis, but mostly because of the better systemic treatment that we have now. This is the mantra that I use for all my patients, be it breast, be it oral cavity, and this is a simple thing that helps me not go wrong anywhere. Uh, First step of diagnosis, staging, and then planning. For diagnosis, I would do a good clinical examination, goes a long way. Imaging, pathology. So if you talk about breast cancer per se, a good clinical examination is mandatory. It helps you diagnose the disease, it helps you stage the disease. In imaging, mammography is the gold standard. Definitely, if you talk about denser breasts, you go for ultrasound. If you talk about MRIs, but again, mammography is the most important thing, and you have to have mammography to look for centricity, to look for the lesions, and ideally should be performed before doing any intervention, before a biopsy. Good mammogram. These are the two views that are most commonly done. Should be read carefully by the surgeon himself or herself. And but again, with the advent of newer technologies, 3D mammographies, digital mammographies, they are coming, and contrast mammographies. But these are the things that you should be aware. A good positioning is very important so that you do not miss the retroareolar lesions or the lesions that are deeper into the pectoralis. Definitely, it's more important, more better. It's better for the fatty breasts if you are talking about ACR A or B, and for ACR D, you have to have another modality either by MRI or by an ultrasound. You should be aware of the BIRADS classification. The important thing is that probably BIRADS 3 and 4A being the most controversial of all the classifications, you have to have a tissue diagnosis in BIRADS 4A, better to overtreat or be more cautious than to miss a disease. Most very importantly, do not treat based on your just an FNAC report. You will have to have a core needle biopsy. It is the way forward. You cannot start your treatment, be it pre-operative, be it any treatment, just based on your FNAC reports. It's important for my surgeon colleagues that a biopsy is mandatory. Even for a smaller lesion, you will have to have a biopsy, because later on you'll see that staging, now the staging workup is based on these IHC markers. Biomarker testing is most very important, and the pathologist will also say that the biomarker testing is better done in a uh, in a core needle biopsy specimen than a final biopsy specimen. Molecular oncology is the way forward now. You cannot have just a be it breast, be it endometrium, you'll have to have a molecular testing now, and you divide it on luminal A, luminal B, HER2 enriched, basal like, and this is what it is going in the future. Staging will not go into the details, but the important part is that the integration of anatomical and biological phenotype, it's not just based on your tumor size or nodal presence or absence. It's based on your ER, PR, HER2 status as well. So you will have to have biomarker testing prior to your treatment. Talking about the management, it's you bring along your team of oncologists. Many good centers, high volume centers, are getting their breast oncology separate from other oncology. They have been started practicing DMG systems, so you go get a good oncology team. It's not a one-man show. It's not a single person who he has to treat the oncology, and you get your surgeons, you get your surgeons, get your medical oncologist, you get your radiation oncologist. It's an entire team. It's not only about surgeons, chemo, or radiation. It's about your onco nurses. It's about your physiotherapist. It's about your radiologist, your pathologist, and the list is endless. Evidence-based medicine has to be practiced everywhere, uh, and keeping the patient at the center of your decision making. The patient, the the wishes of the patient, the finances, they have to be taken into account while making decision for the patient. You have to personalize the medicine, personalize the treatment. One size does not fit all. You have to have a individualization of treatment of every patient, and this holds true for all oncology, not only breast cancer per se. So now, how, before we talk about the surgical management, how it evolved from more debilitating radical mastectomies in which we were removing the skin, the breast tissue, the pectoralis major, because the Halstead theory, it demonstrated that the tumor is spreading from the breast towards the axilla and then to other parts of the body, and how we evolved from a more debilitating radical mastectomies to a more visually appealing breast conservations. So Bernard Fisher, the pioneer of breast oncology, he is the one who is he's responsible for many trials and many landmark trials, many practice changing trials. The NSCBP B04 being one of the most important practice changing trial, in which the radical mastectomies were compared to total mastectomies. In node negative, approximately 1,000 node negative patients were randomized into radical mastectomies, total mastectomy plus radiation versus total mastectomy, and about 500 node positive patients were randomized into radical mastectomy and total mastectomy. It was seen that even after 25 years of follow-up, there was no significant difference in disease-free survival, distant disease-free survival, overall survival in any of the three groups of node negative or any of the two groups of node positive. So it was the practice changing trial that showed that radical mastectomies are not superior to a total mastectomy or as an MRM that we know right now. One important thing in this NSPP04 was that approximately 40% with clinically node negative underwent radical mastectomy had the pathological node positive disease. So we can assume that those who only went total mastectomies without axillary dissection, even those will have approximately 40% will have a node positive disease, but only 19% of them developed nodal recurrence without any difference in overall survival. So there was one hint that axillary lymph node dissection that we talk about, it's the breast cancer is a surgical disease. The surgical disease, it might be totally unnecessary, but yes, this trial was underpowered to demonstrate so. Now, when we have talked about when we have shifted from a radical mastectomy to a total mastectomy or an MRM, so moving one step forward again, can we do just a lumpectomy, just a breast conservation, and not go for the entire breast removal? So NSCPP B06 was the trial that answered it, in which the small lesion, less than 4 centimeter lesion, irrespective of clinical node positive or negative, were randomized into an MRM versus a lumpectomy, a BCS plus radiation, or a BCS alone. Even after 20 years of follow-up, there was no significant difference in disease-free survival, distant disease-free survival, or overall survival. But yes, there was significant difference in loco-regional recurrence between lumpectomy versus lumpectomy plus RT. So radiation is a part and parcel of breast conservation therapy. BCS is not the only thing that has to be done. BCS plus RT is makes it the entire treatment. So now once we have moved from are debilitating radical mastectomy to BCS, I always tell my students breast has to be treated differently, axilla has to be treated differently. You cannot say that mastectomy, if you're doing mastectomy, you have to do axillary lymph node dissection. No, that is totally wrong. Breast has to be treated like either mastectomy versus breast conservation, and axilla has to be treated like either sentinel versus axillary lymph node dissection. So how did it evolve? How did you assess the axilla? A mere clinical examination has a high false positive rate, a high false negative rate. There are various ways to assess the axilla, but what we practice in our institute, you do a ultrasound guided FNAC or biopsy from the axilla. You look for loss of fatty hilum. You look for suspicious nodes. You do an FNAC of the node. If it is positive, you go for an axillary lymph node dissection. If it is negative, you do a sentinel lymph node biopsy. If it and send it for frozen section. If it comes out to positive on table, you do a completion axillary lymph node dissection. If it is negative, you stop then and there. Obviously, there are caveats. There are studies which will defy all these few things, but this is what we follow. This is the onus on the treating surgeon that this should not be that the patient refuses, and so we did an axillary lymph node dissection. So when you talk about sentinel lymph node biopsy, you have to select your patients wisely. Early breast cancers with clinically node negative. In DCIS, although it does not spread to lymph nodes, but if you are planning a mastectomy or a palpable DCIS, I would go for a sentinel lymph node biopsy. Why? Because there is approximately a 30% upstaging rate in a DCIS, converting into an invasive breast cancer in the final histopathology. And then at that time, I don't want to miss my opportunity of sentinel lymph node biopsy. The contraindications have definitely come down for both for BCS and for sentinel lymph node biopsy. But again, a clinically node positive disease, an inflammatory breast cancer, or pregnancy remains the absolute contraindication for sentinel. The indications are expanding with time. So how do we do it? How the best case scenario, the best way to do it is by a dual dye technique in which you inject the radioactive colloid, technetium labeled radioactive colloid, approximately on the day of surgery or one day prior, usually done on the day of surgery. But yes, you'll have to have a good setup. You'll have to have a nuclear setup if you want to practice it with radioactive colloid. There have been studies in India in which the single dye technique has been found to be good enough. But yes, for the larger audience, it's important to know that dual dye technique is the gold standard right now. Blue dye, because of patent issues, because of the cost, we are in Indian scenario, we are forced to use a methylene blue. But otherwise, isosulfan blue was the dye that was initially started for doing a sentinel lymph node biopsy. The role of ICG is coming. The role of ICG has been tried and tested in many trials in India and abroad as well. And its role, that we have tried a few cases ourselves with ICG, and there have been a good detection rate. And you do not, it's comparatively cheaper as compared to radioactive dye, a radioactive setup that you need. So, and you can use a dual dye technique by visually seeing the blue node, and by ICG, you just need a good setup of ICG. The sentinel lymph node biopsy is backed up with strong data. The NSAPB32 trial, in which they showed that it is non-inferior to the axillary lymph node dissection per se, and the Almanac trial, which showed that the better quality of life is associated with sentinel lymph node biopsy as compared to ALND. Yes, if sentinel comes out to be positive, then what? In our setup, we have a frozen section facility, but what if the frozen section reported it as negative, and then in the final histopath, it came out to be positive? Or if you do not have a frozen section facility per se, then you have data suggesting that post-op radiation can take care of your single sentinel lymph node biopsy positive scenario, or based on your ACOSOC-Z11 trial, even a 1 or 2 sentinel lymph node positive may not decrease your overall survival. But yes, you have to take it with a pinch of salt that there are certain limitations of ACOSOC-Z11 in which the laterality of the radiation, and there was the selection bias was there. Now, when we shifted from debilitating axial lymph node dissection to sentinel lymph node biopsy, and from sentinel lymph node biopsy, 1 or 2 lymph nodes, can we stop doing an axial lymph node dissection for them? So now we are moving towards, is sentinel lymph node biopsy at all required or not, and the assessment of axilla at all required or not. Yes, there are trials which are coming forward in which there is no survival benefit of even a sentinel lymph node biopsy. Yes, you'll have to have greater data to, if you want to start practicing these things. You have to have your institution data. It's important. I tell my residents to start collecting your own data, start collecting your own institutional data. There are talks about sentinel lymph node biopsy post chemotherapy, and yes, the data suggests that it is feasible. You have to have at least 2 or 3 lymph nodes, or a targeted axillary dissection approach is important. But again, I would suggest that you do not next day, just based on the data, you do not start practicing it the next day. You have to have your institution protocol of management. So that's why what I say, the team management, the multidisciplinary team is very important in managing the cases of oncology. Very important slide in which the principles of preoperative systemic therapies has been discussed, as the breast cancer is no longer and has never been a solely surgeon's disease. Now it's more of a medical oncologist disease, I would say. Again, it's a controversial statement, but in why initially preoperative systemic therapy was started only to facilitate breast conservation, but sooner or later we realized that it is giving us benefit. Initially the meta-analysis told us that there is no survival difference between preoperative systemic therapy versus adjuvant systemic therapy. So my surgeon friends would say, why not do surgery and send the patient for adjuvant systemic therapy if there is no survival benefit? So the answer is no, because the triple negative breast cancers, HER2 enriched breast cancers, these are systemic diseases. You do not treat them like a luminal A and luminal B diseases. You have to treat them like systemic disease. And early targeting of systemic micromets is very, very important. It gives you a prognostic information whether the tumor has responded or not. You can change your medicines based on the residual disease. Your target is for a pathological complete response, but if you do not achieve it, you change your medicines accordingly. It may give you opportunity for the various research platforms to test your novel therapies. It may allow for limited radiation fields. It may allow to give you a sentinel lymph node biopsy after chemotherapy. But yes, it has to be done in an institution practice, and institution protocol has to be there. The treatment, the sentinel lymph node, the preoperative systemic therapy has to be taken with a pinch of salt. You may be over treating with systemic therapy. You may be under treating with radiation if you underestimated the disease. And yes, there is always a risk of disease progression during preoperative systemic therapy. But what I feel that if the patient has already progressed during systemic therapy, then probably your surgery would not have helped the patient at all. So who are the patients of preoperative systemic therapy? Yes, we know that those who are inoperable, an inflammatory breast cancer, a matted node, an N2 node, an N3 node, a T4 disease, these are systemic candidates for systemic therapy. But the most important thing that I want to highlight, that in a triple negative breast cancer, and HER2 enriched breast cancer, even a T2N0 disease, many institutes are practicing preoperative systemic therapy. They want to achieve a PCR, and achievement of PCR is much has a higher survival as compared to a non-PCR. But yes, again, I would again reiterate that do not start practicing just based on this data. You have to have a team. Your team has to be on board with you. So a word about oncoplastic breast techniques. Now we have talked whether we've moved from radical mastectomy to a more conservative approach to breast conservations. We've moved from axillary lymph node dissection to a sentinel lymph node biopsy, which is the gold standard right now. So oncoplasty, the combination of oncology, surgery, and plastic surgery has helped us in achieving more aggressive resections, more wider margins, and still keeping the breast intact or a cosmos is good looking, and these are things that should be learned by all surgeons that are practicing breast oncology. So there are various methods of doing oncoplasty uh, based on your tumor size, based on your bust size, based on your breast size, the tumor to breast ratio, and you have to have a good talk with the patient. You have to have your markings done correctly. You have to have your the markings done on table while the patient is sitting and not lying down. So an inverted T mammoplasty for 6 o'clock lesion and lateral mammoplasty is a very versatile approach, can be done in many quadrants, in various quadrants, but with a good breast tissue. When you mobilize with in a young patient, you can mobilize at 2 levels. In an old patient, you will again not want to do a skin mobilization much. You have to have a centralization of the nipple areolar complex. For an lower inner quadrant, J plasty or an L plasty is an important thing to master. A round block technique for a perioral lesion, or also known as a donut mastopexy, uh, is a very important good technique for smaller lesions which are close to the nipple. The upper inner quadrant lesions are probably the most difficult lesions to tackle, as if you talk about the cosmesis, because there is the least amount of breast tissue available there. As I said, it's very important to mark the lesion and mark your oncoplasty on while the patient is sitting and not while lying down. The matrix rotation, in which you rotate the entire breast tissue after resection, and from the lateral most incision you can have your axillary dissection. The Grisoti flap is important if you for retroareolar lesions in which you have to sacrifice the nipple, but then you again give a good contour to the patient. You can have a tattooing of the nipple later on. This patient was brought to us after doing a lumpectomy. There was a big scar, an ugly-looking scar. It came out. It was treated. It was treated like a fibroadenoma, and without any FNC or biopsy done. So the patient, in the final histopath, it came out to be positive. We dissected the tumor. We have a big chunk of tissue that has been dissected already. A 5 by 5 centimeter had been removed. We further removed a 6 by 5 centimeter. There was a big cavity. We did a transposition flap. It's not a perforator based flap in which you have to mark all the perforators based on the desmosable blood supply, and it gave a very good cosmesis to the patient. We This was a T3N0 disease, which a triple negative disease, which we and the patient, young female, was very keen on conservation. We started her on chemotherapy. We downsized the tumor, which is very important to clip the tumor beforehand. You can clip it at the start of your neoadjuvant therapy, or if the tumor is big and you want to first see the response of your chemotherapy, you can also clip at after 2 cycles. But yes, clipping of tumor, even if the patient has chosen mastectomy initially, you have to clip the tumor, because you never know once the tumor is gets dissolved, because triple negatives, they dissolve like anything. The chemotherapy, respond like anything to chemotherapy. And once the patient has, after your 8 cycles of chemotherapy, when there is no tumor, the patient will say, "Doctor Sahab, ab kyun nikal rahe hain? Why not go for conservation?" Then you don't have the opportunity of doing a conservation if you have not initially clipped the tumor. So yes, clipping is very important. This is a J-wire guided BCS in which there was an excellent response to the chemotherapy, and we did a lateral mammoplasty with a good cosmesis. So thank you for the patient listening to the audience. Thank you for my organizing committee. Thanks to my oncology team, and most importantly, thanks to the patients who were kind enough to let me use their pictures.
Yes, the
Thank you,
chairperson,
Dr. Thank you,
Dr.
Dr.
Ashish.
Siddhant. Very nicely covered the whole topic. And I must say that the core biopsy is the minimum standard required nowadays, and one should molecularly classify the disease before starting the treatment, and which is very well elucidated by Dr. Siddhant. And one should remember that LCI has been removed from the staging, and breast conserving therapy is now the standard treatment unless and until some contraindication exists for the procedure. And sentinel lymph node biopsy for clinically T1, T2 and 0 disease is indicated. Post neoadjuvant also one can try that, and but the minimum number procured for sentinel lymph node should be at least 3. And
Yes.
dual mapping technique is required in those patients who have received a neoadjuvant. And one should not try to biopsy if one is planning post neoadjuvant sentinel lymph node. So that's a take home, and very well various trials which were discussed by him, Amaros, Song trial, and the very good oncoplasty procedures level 1 and 2. And thank you very much, Dr. Siddhant.
Thank you. Thank you so much.
Thank you, Dr. Siddhant. You are really awesome.
Thank
Dr.
you.
Chaturvedi, are you there?
Yeah. Now I request Dr. Rashmi Shukla to proceed. Dr. Rashmi?
Am I audible, sir?
Yeah.
You are audible but not seen.
I would like to invite Dr. Shwetima Chaudhary, Assistant Professor Radiation Oncologist from TS Mishra Medical College and Hospital, Lucknow.
Your
She did
video
her
is not
MBBS.
showing.
Ma'am, there is issue in something not opening. So
Okay.
she did her MBBS from Sri Ram Murthy Smarak Institute of Medical Science, MJP, Rohilkhand University, Bareilly. And she did her MD in 2020 from KGMC Lucknow. And she is expert in her field of radiation oncologist. So I would like to invite Dr. Shwetima to go ahead for the what are the newer techniques in radiation, just like Dr. Siddhant has discussed about the de-escalation of therapy. So in the field of surgery. So over to you, Dr. Shwetima.
Thank you, ma'am, for the kind introduction, and good evening, everyone. So I'll be sharing my presentation. Is it visible?
Yeah. Seen.
Should I start, ma'am?
Sure.
Yes, go ahead.
So I would like to start with my talk. I will include only early breast cancer malignancy, and in that I have to discuss about radiation therapy, followed by management of the early breast cancers and few updates that are going on, as well as there are few studies that are going on and the trials that are going on in early breast cancers which are related to radiation therapy. I'll be proceeding with that. So the topics that I'll be covering in my talk are the ductal carcinoma in situ, starting from DCIS, what is the current consensus and management, then going with an overview of early breast cancer and what is the role of radiotherapy in early breast cancer, role of radiation therapy in early breast cancer when we are getting 1 to 3 pathological lymph nodes, because there are certain dilemmas, regional nodal irradiation in early breast cancer, which have been explained by various trials, various studies. Then hypofractionation, from where the hypofractionation come, the concept, the rationale, everything about hypofractionation and how has it become the standard of care in radiotherapy for early breast cancer. Next is accelerated partial breast irradiation, that is APBI, the current evidence and techniques. Now RT in elderly, whether we need to give to elderly patients or not. Next is re-irradiation. SBRT is a newer technique, and no, not much studies has been done, but few studies that I'll be discussing and later on can be a part of treatment in case of early breast cancer. Third is the molecular profiling to guide breast RT. So there are molecular assays are there that have been doing, and we need to know about the ipsilateral breast recurrences. So molecular profiling are very essential nowadays. Breast radiation therapy techniques, I'll not be discussing more on this because that is a very elaborate topic, and I need to take a different presentation for that, but I'll keep it short. Recent studies and trials that are being published and that are published in the year 2024 itself on early breast cancer. So coming to whenever we have a patient coming with a lump in the breast, a history and a physical examination is must, and followed by we order a mammogram, either an X-ray mammogram or a breast ultrasound. FNAC is a fine needle aspiration and a biopsy, and along with hormone receptor status are must. So if it is HER2 equivocal, then we'll order for additional investigation of FISH. Mammographic signs of early breast cancer. The mammography is the first investigation that we order to a patient, and we need to know about what can be the signs in case of early breast cancer. These are irregulated, lobulated, ill-defined mass. Some have speculated margins, some are having microcalcifications, some are having architectural distortion. So other investigations that that we can order to a patient is to know the condition of the patient, go for a hemogram, KFT, LFT, chest X-ray, and echo. And when we need to know about the extension of the disease, additional investigations are also required, like MRI breast, ultrasound breast or abdomen to look for distant metastasis, CT scan thorax, abdomen, pelvis, or MRI brain. When serum alkaline phosphatase is raised, then we should click our mind and we should go for a bone scan at that time. And PET scan is also being done. So breast MRI is not the investigation of choice, but definitely it is being indicated in case of dense breast, especially in young females. And we can also diagnose in case of if the female is pregnant, then breast MRI is very useful. Similarly, in case of multicentric disease, and also those patients are having BRCA1 and BRCA2 mutation and having a family history of carcinoma breast. So I'm not going into the detail of TNM staging. This is the latest staging. So starting with ductal carcinoma in situ, by TNM staging, AJCC and International Union for Cancer Control, 8th edition, they have designated as TIS in situ and stage 0 because it is confined to the ducts. So the stage has been given as TIS. Usually these malignancies occurs within 10 years, but some may take even 15 years or longer. Sometimes this DCIS may also present with a second malignancy or may also develop in contralateral breast also. The rate at which they develop is 0.5 to 1% annually. And also DCIS is a part of breast and ovarian cancer. So we can also go ahead and ask the patient about the family history and also can get a BRCA1 and BRCA2 mutation. So what is the ductal carcinoma in situ? Because it is a proliferation of abnormal mammary ductal epithelial cells. So it is neither invading the basement membrane nor it is involving the surrounding breast stroma. So they do not metastasize, and axillary nodal involvement is up to 5% only. So nowadays we are having good screening methods, also good qualities, X-ray also. So previously we have mammography and we used to diagnose around less than 5% of patients. But nowadays, because of good qualities of X-rays and mammography, we can detect up to 15 to 30% of patients. So I will not go about the risk factors because risk factors of DCIS for early breast cancer, for advanced malignancies in breast, they all are same. So majority of patients coming with DCIS, these are screen detected and with no palpable breast lump. Usually when we go ahead with the screening, and we can see that these patients are basically detected on mammography. So again, we need to know that what is the most important thing that we are getting in mammography. One is microcalcification, which is most common finding that we are getting. Rest are maybe found in some 8% or 10% of cases. Other is the breast ultrasound. That is also very important investigation. And in that, we are getting hypoechoic areas. So these are around 48%. So we can easily see the films or mammographic films or ultrasound. And we can say that these are hypoechoic areas, and definitely we can go ahead with the treatment. Breast MRI, I've already been I've told that it is for the dense breast and for high risk groups like BRCA mutation. So this is an X-ray mammogram, just a picture showing microcalcifications, and these may be seen in the form of a linear pattern like this. And this is the breast ultrasound. This is a solid mass, and this is hypoechoic that I have just said. Solid mass, while the other picture is having some heterogeneity, and this will be a mixed kind of tumor, but both lesions are ductal carcinoma in situ. Again, we have to confirm it by the breast biopsy. Sometimes stereotactic core biopsy is an option for individuals having a microcalcification, which is detected on mammogram. So stereotactic biopsy is basically the breast is being placed between the plates of X-rays, and then they are being with the help of different angles, the image is being taken and then followed by a biopsy. Again, we have some differential diagnosis like microinvasive carcinoma, but the nature of microinvasive carcinoma is it invades beyond the basement membrane. Second is atypical ductal hyperplasia. It is defined as proliferation of uniform epithelial cells. So basically, they proliferate and they completely fill the duct, or sometimes they partially fill the duct. So these differential diagnoses we have to keep in mind when we are going to treat DCIS. So in studies, we have seen that these DCIS, they grow along the ducts, and usually they grow in a three-dimensional form. So adequate margin assessment is very difficult for surgeons as well. And also pathologists, sometimes they have some difficulty in like giving out what kind of pathology is. So we can have a frozen section or imprint cytology, and they have reported some encouraging results. So most of this DCIS, these are hormone receptor positive, that is ER positive, PR positive, and HER2 negative. Again, when there is a DCIS, there is one index, that is Van News Prognostic Index, because we need to know about the aggressiveness of DCIS. DCIS can be low grade, can be intermediate grade, and can be high grade, but we have to know about the local recurrence. So there is a prognostic index in which VNPI score is 4 to 6, then it is low risk. If it is 7 to 9, it is intermediate, and if it is 10 to 12, it is high risk. So we need to see that we need to prognosticate the disease based on VNPI index. So the treatment part, surgery, adjuvant therapy like radiotherapy, seismic therapy, but my part is I'll be focusing more on radiotherapy aspect. So radiation therapy is always used as an adjuvant therapy after breast conserving surgery. Although it is sometimes omitted in few patients like advanced age and patients having extensive comorbidities, and sometimes when the disease is of low grade and having a negative margin. But there are several trials, and they have studied about giving benefit of adjuvant whole breast RT. So one of the trial I have mentioned here is RTOG 9804. So 7 years pe, they have studied like local recurrence was 0.9% in RT arm compared to 6.7% in the observation arm. And when the tumor size was less than 2.5 centimeter and margins are more than 3 mm. And when they are followed up for 12 years, then cumulative incidence was found out to be 2.8% in local recurrence with whole breast RT, while if they are kept on observation, the local recurrence was 11.4%. Several retrospective studies are there in which they have mentioned that there is no advantage of giving radiation therapy post BCS. So basically, these patients are low-grade DCIS and low VNPI score. So, and that's why they have mentioned key after post-BCS, if they have low score, then we need not to go ahead with the radiation therapy. And so these are various studies in which they have mentioned overall incidence of ipsilateral breast tumor recurrence. In this NSABP B17 trial, these are basically overall when recurrence, ipsilateral breast tumor recurrence was 31% when no RT has been given and 15.7% when external RT has been given. Similarly, these are other trials and which have shown significant results that adding external beam radiation after BCS has resulted in reducing the recurrence. Now, early breast cancer, we all know that before, just now we have discussed that early breast cancer, we have the standard treatment, and that is the gold standard treatment. It is breast conserving surgery followed by host breast radiation. So this approach has been evaluated by one of the trials, EBCT-CG, where they have mentioned that there is 50% reduction in 10-year risk of first recurrence, and also risk of dying from breast cancer following radiotherapy. Timing of radiotherapy, basically management of breast cancer is associated with chemotherapy, with surgery, with radiotherapy, with hormonal therapy. So sometimes radiotherapy is given after completion of a course of chemotherapy. Sometimes it is given along with hormonal therapy as patient has already started on hormonal therapy. And if it is HER2 positive, adjuvant trastuzumab is indicated, then RT can also be given concurrently. Similarly, with endocrine therapy, RT can be given concurrently. So this is a basically trial that was published in NEJM 2002, and that was a 20-year follow-up, and that is a big trial of 20 years studies. And they have mentioned that BCS followed by radiotherapy has shown to produce survival rates which are similar to total mastectomy in early stage breast cancer. So basically, this was the trial which was done, and 20-year follow-up, they mentioned that overall survival was similar, and also breast cancer specific survival was similar. So in the end, they have also mentioned that when BCS came into picture, they mentioned that it had improved the quality of life in females. And this trial has also encouraged females to enroll themselves and to go ahead with breast conserving surgery. And whenever they are diagnosed with a lump in the breast, their active participation is required. As well as it also helped in the awareness of females whenever they have been diagnosed. Now, coming to role of radiation therapy in early breast cancer patients. So we have 1, 2, 3 pathological lymph nodes and on post-op histopathology. And in early breast cancer, patients who are undergoing basically breast conserving surgery and axillary lymph node dissection. So patient, if coming to us and we are looking and examining the patient, that microscopic nodal disease might be there. So we should be very much aware that around 40% of the patient might develop some nodal disease. But if adequate axillary dissection has been done, the nodes are pathologically negative, then in that case, the role of nodal irradiation is limited. We have to look for other factors, other high-risk features, if we are going to perform regional nodal irradiation. So this is one of the trial published in 2015 in NEJM. They have mentioned the role of regional nodal irradiation in early breast cancer. So this was a trial where they have evaluated the role of regional nodal irradiation, and they took early lesions of T1, T2. Around 95% were T1, T2 lesions, and when they have seen that when they underwent surgery, around 85% of them have 1, 2, 3 positive lymph nodes. And when RT was given in them, then it has improved the disease-free survival from 84% versus 72% respectively. Similar trial was EORTC 922 study, where they have mentioned disease-free survival was 76% with RT arm and 72% who did not receive RT. So when they have been followed for 15 years, there is a significant reduction in two things. One is breast cancer mortality, and the other is breast cancer recurrence. So early breast cancer undergoing sentinel lymph node biopsy. So these are two major trials. One is ECOG SOG Z001 and the other is AMAROS trial. In AMAROS trial, these are axillary mapping of axilla, radiotherapy or surgery trial. So basically they have divided into two groups. One group was T1, T2 lesions and clinically node negative. Sentinel lymph node is positive in 1 to 2 lymph nodes. So if they have concluded that if whole breast radiation is given, then there is no need for regional nodal irradiation in those cases. But there was another group, which is group 2, having similar thing, but sentinel lymph node positive biopsy is positive in more than 3 lymph nodes, requiring regional nodal irradiation with whole breast RT if axillary resection is not done. So basically, this trial was trying to mention that axillary lymph node dissection and regional nodal irradiation, they have similarly axillary control whenever we are treating the patient having a sentinel lymph node positive. Early breast cancers undergoing total mastectomy with axillary lymph node dissection. So why they are going for like total mastectomy and ALND? Because there are some patients of having microcalcification or multicentric disease or multifocal disease, and sometimes they might be having like persistent positive margin post BCS, and sometimes it is the patient's preference. So there was a meta-analysis done, which was having 22 randomized controlled trial, and among they took 8,135 patients. Among them, only 1,300 patients came out to be having 1 to 3 lymph node positive. And when radiation therapy was given to those patients, that helps in decreasing the loco-regional recurrences and also helps in reducing the breast cancer mortality. So we need to know about some additional risk factors also, because there are certain studies in which they have mentioned that not only the size of the tumor, not only the hormone receptor or LBI, but there are other risk factors like lymph node ratio, like molecular subtype, and other things like 4 or more positive axillary lymph nodes. So these are various studies. One is done by Hamamoto et al., Yang et al. So they have been studying different additional risk factors. So whenever we are in clinic, we think about these factors also. Sometimes patient of young age coming to us and the tumor diameter is more than 2 centimeter, 1 to 3 lymph node positive. So we need to know about these risk factors also, and we have to keep in mind that before moving ahead with radiation therapy, are these risk factors are also present? Because again, here the treatment is based on individual basis, individual clinician. So these are the additional risk factors that must be kept in mind whenever we are going ahead and making a final diagnosis. So regional nodal irradiation in early breast cancer. So regional nodal irradiation means we need to treat axilla, then supraclavicular lymph nodes, internal mammary lymph node. It also comes with a lot of complications like brachial plexopathy, lymphedema, some cardiac disease, and secondary malignancy. So again, they are divided into three categories. One is if patient is palpable lymph nodes, but undergoes sentinel lymph node biopsy. Second is palpable lymph nodes with axial lymph node dissection. And third is palpable nodes and more than 2 positive sentinel lymph nodes followed by axial lymph node dissection. Coming to first part, that is meta-analysis, sentinel lymph node biopsy negative patients. So Van der Ploeg has conducted a meta-analysis and he mentioned that the risk of recurrence in case of axilla, in case of sentinel lymph node biopsied negative patient is only 0.4%. And also he mentioned that in case of medial tumors, the chances of involvement of internal mammary lymph nodes is rare. So a uniform consensus was made and it was decided that no further treatment to the axilla is required, neither axillary nodal radiation nor completion of axillary dissection. Another is 1 to 2 sentinel lymph node biopsy positive. So this I've already told about the AMAROS trial, in which after mapping of axilla, either we go ahead with radiotherapy or surgery, because both are considered as non-inferior. Then the third is the role of regional nodal irradiation, who underwent axillary lymph node dissection and more than 2 sentinel lymph node is positive and clinically palpable nodes. So again, they have divided into 3 groups. In the first group, there is no risk factors is there. The second group is having tumor size of more than 5 centimeter, LVI positive, hormone receptor negative status. And in the third group, it is more than 2 lymph node is positive and clinically palpable lymph node. So the last 2 groups that I have mentioned, regional nodal radiation is a must, because in these 2 cases, there are more chances of developing loco-regional failure. So how do we decide on taking a decision regarding regional nodal irradiation? Various nomograms are available online. There is an online tool, breast cancer nomogram, which was developed by MSKCC, and these are having some 9 parameters. Reading the post-op histopathology report, we try to fill on those 9 parameters, and in the end we calculate. Basically, they calculate what is the probability of having the disease to get metastasized, or what is the probability that there are chances of developing disease into some other non-sentinel lymph node. So that is a very freely available, and we can also use this online tool on a daily basis for our decision making. Omission of RT in elderly people above 65 years of age, postmenopausal female, if they are hormone receptor positive and their size of the tumor is less than 3 centimeter, then we can skip radiotherapy. This has been told by the very important trial, PRIME trial, post-operative radiotherapy in minimum risk elderly. Now, coming to hypofractionation. Hypofractionation, the concept came after 2 large, very large trials, that are START A and START B trial. And these 2 trials are having a very long-term follow-up also of 10 years. So coming to START A trial, they have taken early breast cancers, T1 to T3, who underwent either BCS or mastectomy. So they have compared 3 regimes of radiation. One is conventional fractionation 15-25, and the other 2 fractionation is 41.6 gray and 39 gray. But they have kept the duration of the treatment is 5 weeks, and that is same in all the 3 arms. What they found at a median follow-up of 9.3 years, that loco-regional relapse is less in compared in 41.6 gray dose as rather than in 50 gray it is 7.4 and 8.8 it is 39 gray. Similarly, their START B trial was there, and they have compared 2 regimes only, 40 gray in 15 fraction with conventional. Now the duration is different. One is 5 weeks and the other is 3 weeks. Again, we see that the loco-regional relapse is less in 40 gray and 15 fraction. So slowly and slowly, by these 2 trials and evidence-based trials, we have moved towards hypofractionation, and that has become the latest fractionation techniques that we are using in our daily practice and everywhere that is being used. This is another trial in which they have just mentioned 42 and 16 fraction. So all we have seen is now these are the various schedule, but again, which schedule to follow. So START B regime is the schedule which is 40 gray in 15 fraction, and the treatment gets completed in 3 weeks. So because it appears to be the most promising, it has significantly less early and delayed morbidity compared to other regimes, and significantly reduced distant metastasis, as well as it has improved the overall survival. And hence it has become the current standard of care and regime of site. Sometimes we do not do tumor bed boost nowadays, but if it is clinically indicated, definitely we have to go ahead with this. There are certain trials. Now we are moving from hypofractionated to extreme hypofractionation or ultra hypofractionation. So these are the 2 trials. One is FAST trial and the other is the fast forward trial. In the fast trial, pathological 1 and 2 stage, and the regime was 28.5 gray in 5 fractions and 30 gray in 5 fractions. So they have reported. So these were the 2 trials, and so extreme hypofractionation has been compared with that of conventional fractionation. Similarly, fast forward trial, this was the trial in which they have 2 different regimes of 27 gray 5 fractions and 26 gray 5 fractions. And they have compared it with hypofractionation, 40 gray in 15 fractions over 3 weeks. So they found out that similar results were there in terms of loco-regional failure, in terms of cosmesis also. And also it is ease for the patient and convenient for them to complete the treatment in 5 days in a week rather than going ahead with 3 weeks. So this has proved to be a very game changing in treatment for radiation. There are 2 ongoing studies. One is Alliance for Clinical Trials, and the other is the Fabric trial, in which patients underwent surgery like BCS or mastectomy, followed by radiation therapy, hypofractionation, and surgery is basically they have done here is breast reconstruction. So these results are basically, they haven't published yet, but still ongoing. This study is ongoing. So maybe in the next few years, we'll be able to look for it. Now, APBI, this is one of the latest techniques. The rationale is higher dose can be delivered to a smaller target area in a shorter treatment time. So without compromising the tumor control. We have 2 major trials in which whole breast radiotherapy is compared with APBI. So there is no increase in local relapse rate when they both are compared. And also the adverse effects and late adverse effects are less when it is when the treatment is given by APBI. What is the advantage of APBI? Because it has improved the patient convenience. Patient is getting admitted for a few days, and whole treatment is being done 5 to 6 days. It is being completed. It has also reduced the treatment time, treatment cost. Besides that, the radiation dose has not, it is not exposing those to the OARs. So these are the various advantages with APBI. Certain inclusion criteria are there, which is one is by American Brachytherapy Society and the other given by the Astro. So they both have different criteria for APBI. Exclusion criteria for APBI when it is a DCIS and size is more than 3 centimeter, 40 to 49 years of age group, margin positive, extensive intraductal component. Techniques are intraoperative techniques, how we give this APBI. One is by intraop method, by photons or by electrons. Post-operative technique like interstitial brachytherapy using needles or intracavitary brachytherapy. Other devices we have like mammocyte, accent electronic brachytherapy, Contura, and some hybrid brachytherapy devices like SAVI, ClearPath, and by EBRT. These are the various photographs for like interstitial implant we are doing with after removal of the tumor. Post-operatively, we can take the patient in the OT and we are inserting needles like this, and basically the where the tumor is located, we are trying to cover with these needles, either in one plane or two planes. Similarly, mammocyte is basically balloon structure which is being filled inside a cavity after BCS is done, and then it is inflated and it is being connected to the brachytherapy machine and radiation doses delivered. So these are intraop electrons. This is target trial. Various applicators basically they have shown here. This is the accent electronic brachytherapy. This is Contura device. This is SAVI. This is mammocyte. Mammocyte is like a balloon at one end, and they have a connector, and this is being connected to the machine. Available in various sizes, diameters, spheres, or ellipsoidal in shape. Toxicity profile of APBI is different with different techniques. Like if we are doing intraoperative RT, we are getting more of the fat necrosis, but lung fibrosis is lower. But if we are doing Elliot, like electron, with the help of electrons, then more of the damage to the lung. So, and also the cardiovascular events are more when we are treating with Elliot or target based trials. And when this APBI is giving along with EBRT, then more common is the arm swelling, the arm edema, and breast pain also. So this is a newer thing that because patient after BCS and RT, when they are coming with recurrence, the only option was mastectomy. But nowadays we can offer re-irradiation to those patients who have recurrence after repeat BCS. So they have mentioned there is a systematic review where they have mentioned that there is a 13% increase in 5-year local control and 10% in overall survival. Similarly, Jacastro group, they have also, there is a large study by them that is, they are giving re-irradiation in those patients who have developed recurrence, and that recurrence is very small. So they have performed partial breast irradiation with the help of multi-catheter interstitial brachytherapy. So they found out that ipsilateral breast recurrence of around 7% only, single digit, and in 10 years, they have shown the result. But still, a lot of studies are going on. There is one of the study, Preserve Prospective Cohort Study. The results have not yet published, but they are using extreme hypofractionation, 26 grain 5 fraction, for giving re-irradiation to those patients who are having recurrence. Next is another technique of treating tumors like stereotactic body radiotherapy. In this we are delivering very high dose to the tumor just to reduce the symptom burden and improve the local control while minimizing the duration of the treatment. Various prospective studies are ongoing, results are awaited, and one study is using 36 in 48 gray in 4 fraction, and also they are studying this SBRT in elderly age group of above 75 years, and by prescribing 40 to 45 gray. So these studies are still in phase 2 trials, but later on I think we'll be getting some good results when we'll be treating breast cancer with SBRT. This is molecular profiling to guide breast RT. We need to detect the ipsilateral breast recurrence because there are molecular assays are there, and these are very helpful in detecting the chances of recurrence in patients when the patient is undergoing BCS. There's one recent study, randomized trial, and this is OPAR trial. They have compared two different regimes, 30 gray and 27.5 gray in 5 fractions. The primary outcome was adverse cosmesis, which is by photographic assessment. So in the end, they have mentioned that 30 gray is a higher dose and 27 gray is a lower dose. So in acceptable cosmetic outcomes, we need to go with a lower dose, and hence 27.5 gray is considered to be better compared to 30 gray. So breast radiation therapy techniques I will not discuss because breast radiation therapy techniques will include different treatment part, like treatment with 2D technology, with 3D volume based, with IMRT, with VMAT, telling about the different borders. But in a gist, I want to say that that we have been evolved from surface anatomy to X-ray based two-dimensional. Nowadays, we are having CT based planning and moving towards PET and MRI also. And these are also very challenging for us, but they have also helped us in a better giving a better quality treatment to the patient. Besides that, we have a good quality image registration system. We have a motion management system, respiratory gating in case of, like, if we are treating lung cancer or liver cancer. So, so we have evolved from this, and all these techniques are proving to be good and acceptable to the patient also, and very precise, as well as also helps in improving the local control and reducing the toxicity. So we have discussed previously that it is together, it is a multidisciplinary approach. We need inputs from everyone, and radiotherapy is just to sterilize microscopic disease, and it has helped in loco-regional control and disease-specific survival as well as overall survival. So again, regional lymph node is still a topic of debate, because if we are sitting in our OPD and we need to individualize the treatment, that what are the risk factors. So everything must be written, everything must be discussed together. APBI is now an involved, very convenient option, cost-effective treatment option for the patients. Various dosing schedules are going on, and before giving it to the patient, they need to be biologically evaluated. So treatment decisions must be done on the basis of detailed discussion, and also discussing everything with the patient, and benefits and risks. And then we can have a better treatment. We can give a better treatment to the patient. Thank you.
Thank you so much, Dr. Shwetima. It's really a very wonderful presentation. You have touched each and every part of the radiation therapy of breast cancer, starting from the trials, the APBI, everything you have covered, nothing you left. And I will request you that kindly share your slides to me. I will be happy to have that. And
Thank you,
all
ma'am.
the recent Prime and all, you have just Oprah, everything you have touched. And I know ki the time duration is short, and still you have accumulated everything. जैसे गागर में सागर भरना होता है ना, आपने सब कुछ टच कर लिया very nicely, very precisely. Thank you so much. God bless you.
Thank you. Thank you.
Thank you. It was really nice and rightly said by Dr. Rashmi. Gagar mein sagar bhar diya. Really very nice. You have covered everything. If there is
Yeah.
any question, we'll be happy to answer.
There's the Clarinet team. Were there any questions?
It's almost already late.
Yeah, cross time. So anyway, thank you all for the beautiful discussions and beautiful, elaborative, informative, and innovative talks on breast cancer. And really, it was a new dimension to the talks, to the old traditional treatment of breast cancer. And we will always be calling you. And thanks for accepting the invite. And we are honored for having you all with us. Thanks, Clarinet team. And thank you, Dr. Chaturvedi, for giving your precious time. Thank you,
Thanks by all
madam.
the speaker and chairpersons.
Thank
Dr.
you, Dr.
Thank you, sir.
Lakshmi,
Siddhant. Very
Siddhant,
nice to see you.
Thank you
and
for the
Ashish,
opportunity,
Thank you,
ma'am.
ma'am.
Ashish
Nice
Singhal.
to meet you at some other occasion.
Dr.
Definitely.
Siddhant has also very nicely covered the surgery
Yeah,
part. Very
yeah,
clear,
surgical
very,
part.
Very
very easy.
nice,
There was not
very
a lab,
nice.
everything. Yes, yes.
Thank you. Thank you.
Even that is very easy to understand. Very simple, a good picture. It's really nice, Dr. Siddhant.
Thank you, ma'am.
Dr.
Yeah,
Ashish Singhal will have another talk with you.
from
Yeah.
you
I'd like
also.
to have a good surgical oncology on different head
Yes,
and
sir.
neck.
On different
Well,
topics.
very good.
Sure.
Thank you, sir.
Thank you,
Thank you, ma'am.
Shretima.
Thank you. Thank you all.
I heard a lot about you, your prizes. Thank you so much. Okay, thanks
Thank you
for
so much
thanks.
to all the dignitaries for the wonderful deliberation and informative content you have shared to make this session a success. So, with everybody's permission, I'm ending this session here.
Okay,
Thank
thank
you.
you.